10:05 at this point. Appreciate everyone being here. We were going to start with roll call. If you can just please say here. Oh, shoot. I forgot I need to read my little, sorry. Please be advised that this is a public meeting in accordance with open door law that is being live streamed to the public and recorded. The recording will be archived and available to the public for no less than 90 days. By attending and participating in this meeting, you acknowledge and consent to the live streaming and recording of this meeting, including your image, voice, and any contributions you make. For the TCC members, because you're invited to the center, you can unmute yourselves and turn your camera on. Other virtual attendees, if you have a question or want to make a comment, you will need to either raise your hand or let us know via the Q&A, so not the chat, and we will open your line. Then you can unmute yourself to participate. Recording will be published and cannot be edited. Now we will start with roll call. I am here. Jonathan Witham. Greg, oh no, sorry, that's just you. Anzier. On for Dr. Sullivan. Here. Dr. Stride. Virtually, maybe. See Dr. Stride on? I just want to make sure they're able to unmute. No?
This is Dr. Stride. I'm here. Can you hear me?
Yep, good. Thank you. Andy Van Zee.
Here.
Dr. Weinstein. Here. Dr. Jacobson.
Yeah.
Dr. Fitz. Here. Lisa Hollister.
Here.
Dr. Landman.
Here.
Dr. Welsh.
Here.
Dr. Thomas.
Here.
Dr. Woodland. We do have a. Next, I'd like to move to the approval of the May 2nd, 2025 minutes. Have you all had a chance to review? Questions, comments, or corrections?
To accept.
Second. Okay, roll call vote for approval. Beaver, I approve.
Yes.
Anzier. Dr. Stride.
I approve.
Van Zee. Dr. Weinstein. Approve. Dr. Jacobson.
Approve.
Dr. Fitz. Approve. Lisa Hollister.
Approve.
Dr. Landman.
Approve.
Dr. Welsh.
Approve.
Dr. Thomas.
Approve.
Dr. Woodland. All right. Next on our agenda, I would like to invite Andrew Bowman to give an update on a conversation around diversion and EMS.
Dr. Weaver, and all going to say this, may it please the commission. Here today as representative of Indiana chapter of the National Association of EMS Physicians, where I am the state chapter secretary. And I bring to the commission today a position statement and resolution on the use EMS diversion by hospitals. Dr. John Smits, who is an EMS medical director with Hendricks EMS, brought to NAMSP a proposal to basically get buy-in from hospitals and organizations around the state that deal with emergency care, trauma, and otherwise to place a ban on hospitals diverting EMS for the purpose of relieving overcrowding. Showing that through numerous studies that doesn't really improve crowding, it just shifts the burden somewhere else. It can impact patient care and patient safety. Because now going to a hospital not familiar with them, have access to the records from the hospital we go to. Doesn't really address much in the trauma system plan, although strategy 3, which deals with trauma system access, and strategy 4, which deals with EMS, could actually, have language added to address this. But basically, we're seeking the commission's support in supporting this resolution on a voluntary basis, rather than having to go the legislation route, to effectively just say, if you're a hospital, you're going to accept this patient by EMS just because your crowd is not a good reason to divert. You understand that internal disasters, let's say, for example, your heating or cooling goes down. You got one CAT scan and it's down for an unknown length of time. During those circumstances, diversion is reasonable and appropriate. But just for the purpose of saying, hey, we're busy, I don't have a really good bed for you right now, is not a good reason for a diversion. So we do seek the commission's.
Questions, comments? I think to be clear, there is no all statute rules that specify or even acknowledge diversion in Indiana. It is a handshake agreement, I think, between EMS and hospitals to acknowledge that. At any point, EMS could always just take a patient to a hospital, even if they declare they are on diversion. But we have heard from EMS providers across the state that this has become a pervasive problem in certain areas, not everywhere. For example, I think in Indianapolis, they have decided all the hospitals to not go on diversion unless there's a disaster situation. A cybersecurity attack is a good one, right? That was the most recent diversion we had from from one of our hospitals. So I first want to, I think you have a comment, and then I think we probably need to decide if this is something that we feel we are and the ability to come through with an approval or recognition of this. And then I have some additional questions for you too, but I'll start with you, Dr. Thomas.
Yeah, no, I just want to thank Mr. Bowman for bringing this important information to us. This is a topic that I think we do need to address, not just from a state perspective, locally, nationally. We know that there's a crisis for overcrowding, that's not going to go away. But it puts the EMS providers in a very bad position. And I think there's a lot of confusion about what diversion means and when you should be using that term. And just because you have patients coming in doesn't mean that you should shut down your ability to take patients. So from my perspective, I don't see any reason why we shouldn't support this move. And again, if you have your CT scanner, and we've had this happen in my institution. We had a trunk line fire that had occurred, and we had to go on diversion for about 4 hours because we didn't have any electricity. We were on emergency power, et cetera. Those are very rare and unusual circumstances. But I can tell you, as looking at what we provide in South Bend, for instance, shutting down our trauma center access to EMS is really dangerous for our community and makes no sense. Unless it is one of those very specific situations, which you articulated nicely in your document. So I strongly support.
Dr. Stribe, I see you have your hand up, and then I'll go to you, Dr. Thomas.
Yeah, I'm generally supportive of this concept as well. And as you mentioned, this is working fairly well in the Indianapolis area. I would say that we'll note later on in Lisa Hollister's presentation of the trauma data report that there's approximately a 20% rate of unknown field triage and a similar 18% rate of under triage by EMS, meaning not going to a trauma center based on the field triage guidelines. So I think there's a two-way street that has to be about the destination for EMS. I agree that in general, ambulance patients are sicker or more severely injured and shouldn't be diverted compared to perhaps lower severity patients.
Dr. Weinstein and then Lisa Hollister.
Yeah, I was just going to reiterate and comment that for the last several years, Indianapolis, the Indianapolis region, through work done in collaboration with the Indianapolis Patient Safety Coalition, there's been an agreement to not have diversion apart from internal disasters. And it's honestly, it's worked really well. So I do think there's a precedence for it. Their state, I think Massachusetts doesn't have it at all, and they haven't for quite some time. So I think there are real precedents for this. Makes a difference. I would be in favor.
And Dr. Schmitz does indicate in his proposal that Massachusetts has done this very successfully.
Lisa?
Yeah, I'm in complete support of this, especially for critical patients. I don't think any critical patients should divert. So 100% in agreement with this.
Do we have any way to follow this from a data standpoint? If we would, adhere to this, or if people are adhering to it, or if this is really just a word of support and that's it?
That is part of Dr. Schmitz's proposal, is that we use the databases that we currently have or expanding, that we can track this information. So it becomes part of the track data for EMS and the ERs and the hospitals to say, okay, this patient was diverted because of X reason. Make it part of our data process.
Is that something that would have to be built in, or is that already, I mean, I think this is a great idea.
I'm not an expert.
Go to
I
the
could
people.
jump in here. So we were collecting this data during COVID through EM resources. So we could continue to collect that. I will say anytime I ask a hospital for their diversion data, they are tracking it. There's one hospital I'm thinking of in particular that had over 1,000 hours of diversion time in 1 year. So I mean, it varies widely. So you have Indianapolis who's not doing it at all, and you have one. So I mean, I think this is something, in my personal opinion, this is something that is worth addressing, and there are ways that we can track it. I guess we would have no way of knowing, since it is like just a call to EMS and say we don't want to take patients right now. We would rely on EMS, tracking that and supporting that, and or letting us know if there's I don't know, letting who know, right? Because again, it's like there's not a law that anybody's breaking, but just kind of tracking if there's still issues across the state.
It's kind of just a collaborative thing. Hey, we agreed not to do this except for these very select rare reasons. But it's a gentleman's agreement, gentle person.
I think to that end, I mean, it would be great to understand if it's been not a negative thing or even a positive thing, then we could use our, advocacy efforts to enshrine it into something permanent. So that's why I was asking the data.
I don't know if that's state law in Massachusetts or if it's a rule with EMS.
I think it is clearly, like, I don't know.
Codified.
Yeah, thank you.
In which way? In some
Thank
way,
you.
it's codified, understood.
That was the word I was looking.
The hospital association.
Well, it's, well, so obviously we worked on this during COVID and it was a significant issue at that time. I think, the challenge is there are some valid reasons for diversion. And, I think both from a load balancing as well as some of the emergencies, the special circumstances, which are rare, but do occur more frequent than not. Also, I think diversion impacts more of that mid-tier hospital as far as kind of your level 3s or those that are near larger metropolitan areas. So, they have less resources. And so they're the ones that are kind of getting squeezed, with some of this patient volume. And so I think it's worked well with Indianapolis. You've got mostly level 1s and 2s. They have more resources. And so just to clarify, that's Marion County only that's doing the no diversion. It's not the donut counties around Marion. So, I mean, it's an issue that needs to be worked on, and continued. I think it's really comes down to, it's a communication issue between hospitals and EMS and dispatch to try to figure out where the best place is for patients. I think from the trauma perspective, getting the close trauma center regardless that should be the gold standard. When you start talking about some of the medical and I would say non-trauma, that's where it starts to get a little bit more fuzzy as to where the best place is for treatment. I do think the recent state legislative changes that allow for alternative destinations also could help some of this load balancing within the ED to get, use urgent care, use FQHCs, use other alternative destinations for some of these patients as well. So I think it is a much bigger issue than just saying diversion.
think since this specifies it's only no diversion in the case of overcrowding, I think that that's something that should could easily support because it affects every hospital. So I totally agree with everything you said, but since this is specific to overcrowding, I think
Still allows for emergencies and
Yeah.
extenuating circumstances.
Again, we're here to seek support, which it sounds like we. Mr. Schmitz, the original author, Dr. Yazel are taking the organizations around the state. Supporting it. So again, we're hoping with a broad consensus that this become de facto law, although it's not.
But there's potential for that. Should we entertain a motion for the Trauma Care Commission to put forward a statement that they approve? Oh, sorry, Lisa, and then Dr. Stripe.
Yeah, just a comment. I just wanted to clarify a key word that's being talked about. This is ambulance diversion only. This has nothing to do with inter-hospital transfer. So just wanted to put that out there for everybody.
Yep. Dr. Stripe.
I had maybe two questions. One is, does Homeland Security as a stakeholder have a position on this? And then the second is, what is the state of, is it called EM Resource, the database we used for hospital capacity during pandemic? Because I think that will be important to keep that up to date as we move towards perhaps regional strategies or hormones to help some of this load balancing as well. I think that's a future issue, the hormone piece, but at least for now, having some visibility of capacity would be important.
Yeah, I'll start with the first question. Department of Homeland Security, do you guys have a?
I would,
statement?
yeah, I know Dr. Yazel's been, and probably Craig have both been involved with this. My only question, but potential concern would be if we say no diversion, does that do any of the patients an injustice if they are then taken to a facility that has an overcrowding issue? And so maybe to the patient piece, still making sure that that's integrated into the process so that if there's a choice between two facilities and one is overcrowded and one is not, the EMS provider at least has that knowledge to say, maybe the patient will have better treatment options over here. But I'll see if Dr. Yazel or Craig have any other thoughts on.
The EMS commission looked at it and there was broad support. They didn't pass it because it was still a draft. And so they did weigh in, several of the commission members. So yeah, I believe overall we're supportive of the concept. I do agree. And like Jonathan said, I think we need to work on education because there may be times that, you know, while they can't go on blanket diversion for volume, it might do the patient better justice. Maybe that gets to the comment earlier, you know, for critical patients, you know, for patients that are non-critical, then that's a whole different ballgame. So there's some education room on the EMS side for that.
I come from an area that did away with diversion as well. And we've actually seen improved communication between our facilities and EMS because they'll say, hey, you know, we're getting crowded in. Also, if an EMS unit comes and waits 30 minutes to offload a patient and finds out the next hospital's wide open, guess where they're going next time? So there's some automatic smoothing of patient flow that happens with that improved communication. And always our patient autonomy is first and foremost. You know, even in the area of diversion, if a patient said, nope, I don't care if they're on diversion, I want to go there, they still were. So the patient gets some choice, but hopefully that'll improve the dialogue versus, you know, no, we're on diversion, you shouldn't have come here, you know, facilitative kind of discussion.
Yeah, if you look at the data around this, the decision to go on and off diversion is very arbitrary and every hospital treats it a little bit differently. Sometimes it is, you know, the charge nurse in the ER making the decision. Sometimes it's a CMO or like the administrator on call for the hospital. But it varies widely how and why they make these decisions. And also if you look at the evidence, it leans more towards poorer care if they are diverted because it's a delay in care. Often it's a hospital that they maybe don't get their services from on a regular basis. It doesn't support that going to the next best, closest, most appropriate hospital isn't in the right interest of the patient. And I think to the other points, you know, the evidence shows that it actually doesn't help with overcrowding. It is like a quick Band-Aid. But then you're right back to where you were. Or another, I mean, what we see happening is one hospital goes on diversion, the other one gets overcrowded, they go on diversion, and then everybody has to go off diversion. So it's just this constant flipping of switches, which is not good for EMS who's driving around in circles or for the patients. Now you know my opinion about it.
My one suggestion is talking to Dr. Yazzo, the author of the resolution is an ISMA member, would encourage him to put forth a resolution so that they can help. And then we're blessed in Indiana that the Medical Association and the Hospital Association actually work together. It's a novel concept. And I could see this would be an area that the two organizations can help when it comes to the advocacy.
It is my understanding that Dr. Schmitz is going to take the ISMA himself.
Okay, at this point, it would be considered a late resolution. So I would,
I'm not sure where he is in the process.
Okay.
He has discussed it that there's a convention coming up or a conference coming up with ISMA.
September.
He did mention that he was going to take it to that meeting.
So to answer Dr. Stribe's other question, we are working on either bolstering EM resources, or I think there's an opportunity for an RFP to look at another. There are some, I know Evansville really utilizes their EM resource type way of communicating, and even like, you know, specifically shares, you have a interventional cardiologist available, right? So EMS and hospitals, and it helps with interfacility transfer, are very clear and aware where everybody's at. So you could even kind of flag yellow, even if we have no diversion, to say, hey, we're super tight. Maybe this isn't the best time if there's something else. Lisa, is that an old hand or a new hand?
It's a new hand. I just wanted to point out, there's a document online that Dr. Kaufman had written a couple years ago. I don't know if you're aware of it, and it's from the Indiana Department of Homeland Security that describes diversion and like the recommendation. I don't know if you're aware of that document that lives out there. And it specifically states that EMS does not have to divert a critical patient. So I didn't know if you were aware that that's hanging out there.
Thank you for that.
That's
Okay,
the interim. That's what we're telling people now. We get a conflict in a region and we share that document.
I mean, the feedback I hear from EMS though is that these are their partners. And so if they're telling them like, you can't go, right, they feel bad just going against it. And so I think EMS is looking for us something that this would be the right direction to go as a state. So at this point, I will entertain a motion for the Trauma Care Committee to approve this mission statement on use of EMS diversion for Indiana.
Second.
You can have a motion first.
Now you can.
Now,
Now you can second.
I'd like to second.
Thank you. I will have to roll call vote here. And if you feel like you need to abstain, then please abstain. I myself approve. Jonathan Witham,
Yes.
Ann Zier, Dr. Stribe,
Approve.
Andy Van Zee,
Stain.
Dr. Weinstein, approve. Dr. Jacobson,
Approve.
Dr. Fitz, Hollister,
Approve.
Dr. Landman,
Approve.
Dr. Welsh,
Approve.
Dr. Thomas,
Approve.
Dr. Woodland. Oh, okay. And Sarah, do you want to vote on this or do you not hear enough of the discussion? We will move on. The motion passes.
Thank you.
Okay, moving on, IDOH update.
Since it's coming up, can we invite our EMS partner back to let us know how this is actually going and
Yeah,
data around this maybe in a year?
absolutely.
To be able to, yep, just the arrows.
So I bring, the commission has seen these documents already. I've sent them out a week or 2 weeks ago. Really just wanted to get more comment and see if there was anything else the commission had anything to share along some of these track development documents. I have highlighted here, you have hard copies in front of you and again, email. Just some highlights of each of these areas. So I'll start with the bylaws. So we initially put together a rough draft of bylaws last year before we had funding for tracks. And as we've been fortunate enough to progress and have the opportunity to put in within each region, we had to go back and adopt our bylaws to kind of reflect some changes that we feel are needed to better support leadership within the tracks and the fairness and the transparency. So with that, some of the larger points to bring up are the advisory committee within each track. That will consist of the current track leadership, so your chair, vice chair, secretary. We're going to also bring treasurer. You'll see in that those are a leadership position as well. The advisory committee will help bring in more diversity, more discipline, so that when something is brought to the track for funding, a little bit more about the funding process, it isn't lying on the shoulders of just 3 or 4 folks, you know, that may all be trauma centers or may not. We're looking to have from each emergency preparedness district a representative from trauma center and a non-trauma center, realizing that in District 9 we don't have a trauma center, so it's like we have 2 non-trauma center representatives. That will be from each preparedness district as far as the hospital representatives. Then for the region, we're looking at an EMS representative and a rehabilitation. So I feel like those are all voting positions, and then they have an opportunity to many different represented. These go before the track leadership. That's the first kind of major change to the bylaws. I'll see, does anyone have any suggestions, comments, concerns? These have been shared. I will share. This has been shared with track leadership as well. They're aware of these changes. We've shared them at the track levels. Nothing there. I'll move treasurer position. Another leadership role that's been added. We knew that treasurer would eventually, again, fortunately, we've been able to do the funding sooner than we initially, I think, expected. So obviously we needed a treasurer position. So that will add to the leadership ranks at the tracks. We'll add a treasurer position. And lastly, I wanted to point out, we did add terms and guidelines for roles. So no one's going to sit and get stagnant and not ever change, right? So there's an idea of certain positions within leadership and then within advisory committee have terms. So and we have them staggered so that everyone leaves at the same time. And then we're lucky that we have some historical knowledge as we go through these. So with that, we will keep track between the secretary and the regional clinical coordinator for that region. Who's on what term? There's a whole voting process behind that that I don't think we get too deep into today unless there's comment or concern. But those are what I want to share as far as bylaws. Is there any questions, concerns, comments? Shoot you through those. I'm going to move on. Request for funding. So I want to make sure I thank the regional clinical coordinators. Tim Huber, Nicole Raylander, and Sonia Hughes for the whole state as far as your contacts and tracks. They've done a phenomenal amount of work on all these documents to make sure we have support, all the operational needs for these tracks, working closely with their track leadership as well. So we really have 2 pathways when it comes to requesting funding. There's a pre-approved pathway. Basically what we use now, and there's some folks in this room that may be familiar if you've taken advantage, worked closely with Madeline Wilson at IHA, and that those educational opportunities and some trainings have been vetted through our education and outreach subcommittee. So we're going to continue to move forward with those initially. Tracks will have the opportunity to kind of dive in as once their advisory committees are formed and, you know, kind of tweak that if they feel for their region. Maybe one training isn't or maybe there's one that they feel needs to be added. So tracks will have that autonomy as they continue to mature. But to get us up and running, we're going to follow the guidelines that we kind of set forth with the education and outreach subcommittee. They're a great group and they do phenomenal work. So the other pathway is kind of labeled as the other, and that request is really anything that's not in the pre-approved. So it could be equipment, which we're probably going to hear a little bit more about later. It could be another training or instructor course that has either come up or changed. whatever it is that's not pre-approved, it'll go through. And you've seen those forms, I believe. And there's really use case and like, how broad does it go? Are we talking local community? Are we talking preparedness district? Are we talking the whole region of the state? So with that, we do have a scoring tool. And that was put together to kind of help us for the advisory committee and the track leadership, just to put some activity around it to say, okay, this is not just helping hospital X. This is going to support a whole region or multiple preparedness districts. Any questions or comments regarding funding?
Is the scoring tool is for use only within the track or is for use elsewhere? And is it mandatory use or is it just an opportunity?
So the scoring tool will be utilized by the advisory committee and the track leadership when they vote on these. It doesn't have to be used. I mean, unless the track leadership and the advisory committee say this is the absolute, knowing that these are still maturing, we want to just give that option and put some more backbone behind it. But I think you can see it, and I can pull it up. I just don't want to take too much of the commission's time, but it's pretty useful just to get an idea, right? It's kind of
The resource.
yeah, absolutely. Okay, hearing nothing else, I'll move on.
Question on West for track. The dollar amounts listed, those are up to those dollar amounts, not dollar amounts specifically, is that?
As far as a pre-approved, yes, that's what we kind of set out with based on initial. She did a ton of finding and kind of like scouring through different states' work and then what we got from different people within our own state. So that's right now set as kind of an.
I think we should probably just clarify that in the document. That otherwise, it's not just you get $800 for ATLS. If it's $600, you're only going to get up to whatever of the cost.
The next document, I just wanted to kind of overview for the operating guidelines. We put these together really just to kind of help put some structure behind. As we know, we have brand new track leadership. We're going to go to the advisory committee. There's no precedent set. We wanted to give some guidance behind that. So not just a free for all and not really know where we want to have some direction. So we took areas that we were part of the trauma system plan. We've taken things that we worked out at different subcommittees within TCC, and some of the areas outlined: education, trainings, registry, injury prevention, EMS, and even within those, there's trauma center, non-trauma center, communication. These are all, again, kind of guidelines that help drive the tracks towards to their regions, areas we want to work on. Again, these are overview, gently steering the ship. Tracks will get together. You're going to hear in a moment from the tracks when we talk about strategic plans. This will help drive those strategic plans so they can focus on the areas of interest within their regions that make important to them than another say. So it's a little bit more of a little lengthier of a document, but I wanted to, again, put some kind of backbone behind what we're looking at to do with the track. Is there any comment or concern from the commission on this document?
Vince, I have a question, and I may have just missed it in reviewing this, but is there any explicit statement of deliverables to this commission and a time frame for those deliverables?
You are so on it. That's actually my next, I think my next slide of the one after talking about.
Didn't plan me to.
You're good at what you do. So I will get to that if there's no other further comment for guidelines right now. And please understand too, we look at these as living documents, right? So as trauma system plan changes, as we kind of look at that as a living document, these can flex and follow suit and the needs of the region. Strategic planning. Won't spend a ton of time on this because you're going to actually hear from the tracks and their strategic plans. Basically, the ask here was, I gave a very one-page rough outline. What are your areas of interest? Where would you like to spend your money? Give us an idea of, I want to put 20% in education. I want to put 40% in training and so on and so forth. and then give me some kind of objectives within them. So those are shared with you as well. We're going to get more into it. Part of that objectives are how are we going to measure it? So how are we going to know? And that's going to lead me to accountability reports. So these are metrics based around the objectives in the strategic plans. They're going to always include financials, be it how much we spent on those pre-approved, how much we're spent on the other asks, as we call them right now, participation. So not to get too into the weeds, but we're asking that the folks that are going to participate in this funding have some skin in the game and they participate. We're going to make sure the facilities are inputting data. So our regional clinical coordinators are working alongside with our surveillance and evaluation team, know which hospitals are not supporting with trauma data, trauma centers or trauma centers. They're working with them already. So by the time we get much further along here, most centers, barring some other problems, will be. We've been working on that for the past few months already anyway. But we'll know who is as far as other rehab and EMS and things like that. Nothing punitive. It's not a report out to say, it's more to how do we knock down barriers and make it more inclusive. That's the goal, not, again, nothing punitive. I think it's right along lines with what Andrew Bowman shared earlier with the diversion and Dr. Weaver spoke about with the teamwork between EMS and our facilities. So the discussion point I wanted to make sure that I brought up and didn't miss with the commission today is along your lines. How frequently do we want to go? I'll just throw the example I've been using. Do we do a quarterly report that goes to UH/subcommittees based on, the report out if it touches education or disaster preparedness or whatnot? And then maybe a yearly report that comes to this commission. Do you think there needs to be a bi-yearly report to the commission? Any thoughts on that right now? That's kind of, there's examples in your packets of some of the reporting, but we don't really have a strong sense and we wanted to get some comment.
So I think, what you've documented here is from a kind of an administrative perspective, as far as participation, funding, kind of spending. Probably the next aspect is including more of probably the PI efforts specific. Now, I think this as a commission needs to probably set what are those statewide targets that tracks to focus on, and then their regional plans funnel into kind of that state focus, but that's kind of the next iteration of this more administrative.
I'm like a very story-based learner. So can you walk me through, because I think this is what I'm having trouble visualizing a little bit, is the process through which the tracks, and maybe this is outside of the scope of what you're present, so if it is, like, just let me to relax. But the process from which track says, okay, here's our strategic plan. These are the things that we think are important in our region. This is what we'd like to focus on. Here's who we have, to implementation and spending and accountability. Like where does the rubber meet the road in terms of their then interaction with this committee, with your office, and oversight to ensure that we are actually continuing to address the issues that are what our goals are, and that we're doing it appropriately, I guess.
No, I think your question is very, very along these lines. So I'll to dissect it in outside of that order. So the first contact between TRACS and IDOH Trauma and Injury Prevention are original clinical coordinators. They work closely with the TRAC leadership teams. They're there for guidance and support, but they're also part of the foundational building. Like they're a leadership role within it, but they really are, right? So they're going to help make that bridge between what's going on with trauma and injury, what's going on at the regional track level. The part of that touch point is you're going to see today the strategic plans, each track, that's going to be for a vote. So that's going to say, okay, you guys are on the right track, or maybe we need to see X, Y, and Z before we. So I think that's going to help answer that question to make sure that it's in line with what the commission's goals do. And you're going to see that here. So
I agree with Andy. And it goes back to your question. I would expect the tracks would have to come here and report, and I think it's a quick slide on their participation and then a quick slide on their budget and how they're using it, but it is very much followed by how they quality improvement efforts, education efforts, system development efforts to move the needle forward. Now that goes back to the expectation that they're developing metrics, but they need to come and report on the progress. Now, the frequency, we meet 4 times a year. Maybe it's once a year, but I'm open to other suggestions. I think expectation for them to come forward and report.
The only consideration I would have if track is not projecting to utilize all their money, and this is a financial thing that we need to address by either moving funds around or addressing as a statewide commission. We should have that notification earlier. Times a year.
Yeah, I think it'll depend, like the administrative could be still a quarterly report that we receive, whether they have to come do it, or it may just be part of our packet. But, I think it depends on what the metric is as to probably the frequency.
So like a full report on everything once a year, but every time we meet, we should be seeing how they're doing financials. Is that what you're trying to say? Okay. And then we would see you have not spent any of your funding. What's our plan? Because we're running up to the end of the year.
Yeah, and then we can, as a commission, choose to shift
Sure.
that track and getting those resources utilized.
Makes sense. Any other comments? Anybody online? Lisa, Dr. Stride? Dr. Zara.
I think the strategic plans will be helpful in kind of explaining some of this.
And should be.
Oh, it is? Okay.
Yeah. When she maybe initially hopped on it, right, and she couldn't, but when I saw her come on, I enabled it. So she. For me, I'm gonna hand it over to.
So I guess we as a committee probably should approve these documents. I guess I would entertain, or I will submit a motion for the approval of the 4 documents that were presented to us as the approved initial draft. Would also give the flexibility for both IDOH at the direction of one of these, or one of our subcommittees, to make appropriate updates to those documents as necessary.
Seconded.
So the motion on the table is to approve these 4 documents and give IDOH and the subcommittees the authority to update them.
The thing I would say in comment is, one is called a bylaw and the others are called guidelines. And does that change how we think about them? Are they all guidelines? Or, the language may matter in terms of how we, particularly with change. Usually bylaws are a little bit more set in stone, and there are either amendments or.
So I'll amend my recommendation that bylaws can only be amended by the commission, and that the other guideline documents can be amended at the direct discretion of the committees.
I'll share, for you final votes here. The bylaws, if you go through, do have an stipulation on amendment well through the track level. So I don't know. I hate to see get caught up at TCC if it's something as simple as.
Tracks should not be amending the bylaws themselves. Otherwise, we're going to have 3 tracks going in opposite directions, creating their own bylaws and all that. The tracks exist because of this commission. I think the commission itself should be the standardization of the bylaws.
I agree with that. And then the track has the ability to change their guidelines.
They may have their own operating guidelines. I mean, as far as internally, yes.
And you want to amend your motion again to strike 7, which is the amendment section, or you could modify it to say that these bylaws may be amended by the TCC.
So it just would say these bylaws may be amended by the Trauma Care Commission. I think the rest of it's fine. We'll just take out, these bylaws may be amended by by Trauma Care Commission. Just say that, right? Provided the proposed amendment is available the days prior to the meeting. Try again.
Yes.
Just start, just
Maybe
start.
easier to separate them, I don't know.
Move to approve the bylaws as amended.
Second.
I think if you say I have motion to approve the bylaws with the amendment of changing it to the Trauma Care Commission would be the right way of saying
As you stated.
that.
Second.
I have a second. Okay, so the motion on the table is that we are going to, the trauma is to approve the bylaws with the change of Article 7 to state may be amended by the Trauma Care Commission. And I have a motion in a second, and we will go through. I approve. Jonathan? Dr. Zier, are you able to? Go ahead. Unmute.
Give a thumbs up.
Let's give a thumbs up. Perfect. Okay, Dr. Stride,
Approved.
Andy,
Approved.
Dr. Weinstein,
Approved.
Dr. Jacobson,
Proof.
Fitz. Approved. Lisa, Holster,
Approve.
Dr. Landman,
Approve.
Dr. Welsh,
Approved.
Dr. Thomas, Dr. Woodland.
Second, move to approve the other guideline documents with the caveat that they can be amended at the discretion of the department and or the commission subcommittees.
The first motion approved. Now we have a second motion. New motion.
I can second that one.
Second that one. Okay, the motion on the table is to approve the guidelines with the addition that they may be amended by the Department of Health or. All right, I approve the motion. Jonathan Wickham.
Yes.
Dr. Zaire.
Yes, I finally am able to unmute.
Dr. Stride.
Approved.
Andy Van Zee.
Approved.
Dr. Weinstein.
Approved.
Dr. Jacobson.
Proof.
Dr. Fitz. Approved. Lisa Hollister.
Approve.
Dr. Landon.
Approved.
Dr. Welsh.
Approved.
Dr. Thomas.
Approved.
Dr. Woodland. That motion also says, thank you, everybody. Thanks, appreciate it. Dee and Dr. Stride to present the Trauma System Planning Subcommittee report.
Yeah, so I'm going to be brief because some of what we talked about at the subcommittee, trauma system planning subcommittee was what we just approved. As far as the state trauma plan, we did look at kind of pacing of that document as well as progress. We continue to, I think, work towards kind of that structured document and achieving state staff kind of going through, highlighting things in the red, yellow, green aspect. I do think that now that we have talk about the actual track plans here shortly, but kind of I think we as a commission need to then look at priorities for the additional funding as we kind of look at the overall plan itself. Trauma Regional Advisory Committee development, so those continue to occur. See the 4 documents that we just approved. We discussed that. We need recommendations to send that out to the entire commission. State did just approved. Trauma system designation. We continue to work with 3 areas within the state that have interest. There's actually potentially a 4th that has reached out. each of these are kind of, say, things as far as kind of the discovery or working with their medical staff. And so our hope is to continue to have conversations with these organizations. Hopefully, I think we can also work with the track so that it's not just the subcommittee or the state level work tracks, well, to try to help these organizations, regions, hopefully move forward with level 3 expansions here. And then just a list of kind of the 2025 recertifications or re-verifications. You can see a fairly busy year. So we've got a few more scheduled for the rest of the year, as well as then several here throughout the state that have completed their initial either visits, either received their verification, and a couple that are waiting validation from their site visit. Any questions? That's kind of a brief update.
I just want to say thanks to you and the system planning team for your great work on these documents. And that is a lot of verifications. I know that takes a lot of work, even though we moved through this information pretty quickly. And also congrats to all the hospitals on your verifications. I know that also was a bit of time and effort in looking at data and presenting it. So congrats to all of you guys. Thank you, Andy. Any other comments, questions? We get a round of applause for all of our. All right, strategic plans. We're going to start with our northern region. And Lisa, I believe you're presenting.
All right, so there's nothing on my screen on Teams, so hopefully we jive with what I'm saying and what's on your screen. So I think, Brian, you're going to advance my slides.
Yep.
Okay, so in the North Track, right when I heard that we were going to have money, I immediately started working on a plan. And so I'm just going to go through this really quickly. I think these were sent out to all the commissioners. I'm not real sure if you have the printout in front of you, but just trying to keep it really, really basic and aligned with the state trauma system plan and those operational guidelines for the track that you saw. So the next slide, please. So regional integration and operational support. So digital platform for all the basic communication that we do in the tracks, quarterly meetings and officer support, and maybe even more meetings than that. Next slide. EMS and inter-facility transport. So collaborating with the EMS Commission and all of EMS and EMS education, and then targeting what gaps are there for trauma care with EMS and working with them, not providing all the support, but working together. So this is the one I put a fire emoji because this is the part I'm really on fire about is the regional data infrastructure reporting and performance improvement. So we cannot create a system or a better system without the data. And we don't know, we have no idea on data we're not receiving. And so this is hugely important for me. We need to consolidate all reporting functions. We need to assist with all the trauma registry training, and we need to monitor some PI initiatives. And Andy, I appreciate you mentioning, to start putting in some quality parameters to monitor and make future funds available related to those quality goals. So I love that. Next slide. Clinical readiness and standardization. So CME and trauma education, for the hospitals and everybody related to that's providing trauma care, trauma certifications, and then mentorship, the trauma centers mentoring non-trauma centers, creating an all-inclusive system, and everybody is part of this. Then injury prevention and community outreach, targeted prevention campaigns related to the data that we're seeing in the northern area. What are our biggest problems? Community partnerships with local health departments and schools and really everybody on how to prevent injuries, and then monitor all of this impact and whether it's working. Is prevention working? Disaster preparedness and coordination, support the planning and exercises along with the Healthcare Coalition, working with them to maximize all of the federal disaster preparedness money. And then local funds on gap analysis, simulation support, pediatric preparedness, and then our own regional needs. integrate trauma assets and communication into multi-agency response plans, supporting those RMOCs that we keep talking about. Evaluation and sustainability, this is key. And this is where the data comes in. We don't know if we're improving unless we have this data. And we need to validate that if we're spending this money, that it's been put to good use and we're improving our system. And so when we look at the funding itself, I put a huge pot in that registry category. And so in the first year, you see $212. And this is specifically for each trauma patient that each hospital receives. So this portion would be automatic because we want that data. And the only way to do that is to incentivize. And then the rest of the pots of money you see there, those would be based off of that kind of that advisory committee in each track that supports the grant requests in those different categories. And then really the next year is exactly the same. It's just a larger pot of money for those specific categories. And if I go back to the slide on the first year, you see where it says that 12,140 on the data infrastructure. That's how many patients were in North Track last year. So if we just kind of did some simple math, it's like $70 per patient to support every single hospital. It doesn't matter whether you're a trauma center or not. Every single hospital needs support to get that data in. And that's where we have to begin knowing where we stand in baseline today. And then just the last slide is on questions. And Dr. Thomas, if you want to speak up, he's the co-chair for North.
No, great job that you did an amazing amount of work, especially on this budget allocation. And you took the lead on that.
I have a question around the data. I agree that incentivizing may be the only way to get everyone's participation. Is this around incentives per patient, or is this some sort of data infrastructure that should have at the state level already? Or I guess just flush that out a little bit more for me, please.
So in that first year where it shows the 212, that would be divided among the hospitals on a per patient basis.
I do think, as you look at each of these plans, there's an opportunity for us to look at, are there statewide initiatives and funding specific to which will improve and help each of the tracks with respect to data reporting and that aspect. I don't have any qualms with providing incentives per se. I was just wanting to make sure it wasn't something that we should be doing as a state as opposed to track trying to tackle something.
When you say something we should be doing as a state, elaborate just a little bit more.
Well, if you're doing this because for instance, the registry isn't supporting your needs, then we as a commission should come together and make sure that the registry supports each track's needs. But if this is
Okay, when you say registry report support, do you mean more in terms of, are we getting the data? Are we getting it out of the database? That I don't see as an issue. And I will probably describe that a little bit more in the registry report out.
And then, I mean, the other thing, and it's just 10,000 in your first year, but digital platform, I think it probably would behoove the commission to figure out a way to have a digital platform for every track. We talked a little bit about this on our education subcommittee meeting.
And right now they're using SharePoint.
Right.
I think to your point, the Trauma Care Commission has the opportunity to say, we have identified this to be an issue that needs to be addressed statewide. So we'd allocate funding from the commission directly to address said issue, whether it be updating the registry, a digital platform. And I also agree with Andy. It's like, look, we need to be hearing from the subcommittees what they identify as opportunities and elevating that as a statewide opportunity. And then we 100% would save funding to just do it as a statewide solution rather than trying to do it individually. But it doesn't sound like, Lisa, that's what you're going to be using this funding for.
No, because that is another issue.
I will say, I think great job. I love the direction, and we'll look forward to seeing some of the metrics that you guys are going to associate with each of these areas and your goals of where you hope to see the northern region move. And then, of course, some details around the plans So thank you for this. I think it's a really great start.
Thank you.
We will move on to the central region. Is there any other questions or comments? No. Caitlin Sheridan. Caitlin, if you want to introduce yourself to everybody too.
Good morning. My name is Caitlin Sheridan. I am the trauma program manager at Ball Memorial Level 3 Center up in the chair of the central track. So for the sake of time, we were given Lisa's proposal to use as an example, and we really thought it was beautiful. So all the work that you put into that, we weren't going to flex and try and change it a lot because we thought it was pretty awesome. So just for the sake of time, I was just going to point out the few changes that we made and then go over the dollar amount. So the strategic goals and funded initiatives on how it's broken down, we kept the same categories. What we had talked about and some feedback from our track was we added in approved resources as requested for EMS on top of kind of the clinical readiness and standardization. So just to make sure those resources, the way it was worded, there was some concern that those were only allocated for hospitals, so we added it that way. And then additionally on the goals, we added in the research and distribution of evidence-based practice. So as the sustainability and evaluation piece, using the data and the PI initiatives that we're tracking, especially some of our level 1 centers downtown, putting that into articles, abstracts, and kind of dispersing that evidence-based best practice. Here is how our budget was allocated, very similar to the North Track, just a few changes based off our demographics. Also, I can't remember if we pointed this out or not, but we had proposed for our advisory committee to have a rural EMS representative as well as an inner city representative, just because we felt like that would better serve our track with the diversity that it encompasses. So very similar layout. We thought the vision was very appropriate to really put the emphasis on the data initially, and then kind of that clinical readiness for our trauma and non-trauma centers. And there's in year 2 just with more dollars.
Questions? I think the same comment to you guys. Would look forward to seeing some, some key performance indicators, metrics, where you're at, where you want to go, and details around how you plan to get there. Sure. Yeah, thank you. I appreciate it. All right. Moving to the Southern Track and Kim Huber. You can introduce yourself to everybody too. Appreciate it.
Kim Huber. I am the Southern Regional Clinical. My leadership was unable to make it today, so I'm going to do my best to represent our strategic plan. It's more than one page. It's pretty large. A little backlash. We've had a few transitions within our leadership. We've had a change in chairs, and right now our co-chair position is vacant. So this is just supposed to be really just used as a guideline. Again, kind of following a living document. For backstory, that these strategic plans were built in these meetings. And we tried to send out a regional needs assessment. I only got 11 responses out of 25 hospitals. So for year 2, we're hoping that year 1, we can do another regional needs assessment, really increase engagement and collaboration, do better. So those are our strategic areas, and I will just briefly propose an effort. We're really trying to follow suit with the state performance indicators. When those are settled, hopefully looking to establish our own indicators. And leadership also, they really want to focus on capital purchases this year. So like a shared regional mannequin, look at least one high fidelity simulator, and then kind of reassess that used funds and potentially another mannequin as well. Regional data capacity and support. We do want to provide every hospital non-trauma centers with the formal registrars training. Your AIS 15 trauma ICD courses. And as well too, trying to increase collaboration in the southern region, meet separately with all these registrars. And do convening and what they need on that southern region, because again, we're rural, we have a lot of white space, a lot of small hospitals. Trauma-focused education across the continuum, so that's just those pre-approved courses, pre-hospital, hospital, and rehab. And then any other ones that they feel is that are trauma-related care. Injury prevention and community outreach. We are hoping to monitor the quarterly track report. And it's gonna hopefully provide funding to the top 5 mechanisms of injury. So people, the hospitals can request funding. Disaster preparedness is another opportunity to make capital purchases. I spoke with another regional clinical coordinator in another state. They have a trauma trailer and they have MCI inflatable mannequins, and they say that that is their most used equipment. So hopefully talking with our HCCs and partnering with them, hopefully have the opportunity to buy those and stick them in each district. That's where we're looking to spend down that one. And then abstract sustainability, that again, hopefully for the website searches as well. We wanted to have our own website for increased communication. Hopefully look at nonprofit status, and then that is where we're going to create, hopefully by the beginning of next year, another regional needs assessment to send out and really focus on strategic planning for year 2. You guys can see I'm a writer, not a speaker. Do you have any questions?
Just, I guess, an observation. One, I really like the detailed level as far as not just the objectives, but really the tactics for each of those objectives that is in the Southern plan. The ask, I think, is to figure out how you take this plan and probably make them all look the same, just from so that they have the same structure as far as the look, but overall, it's a good.
I think our team can work to help. Just kind of thinking through some of your comments, are you having difficulty engaging people in the southern region?
I'm trying my best. I know Madeline is trying as well. So we, not by much, but we have the least percentage of even people utilizing the education reimbursement that we're currently doing. I think it's like 50% in the south, maybe 51, 52. So not a huge, but we are the lowest. Hospitals too, so.
It's also the most independent hospital. You don't have large systems compared to most of the other. As well as you have a little bit of bleed over from other states where the others don't have that same setup.
And then we have the only district without any trauma center. District not doesn't have any trauma centers. We're the only district in the whole state. So that's why it's 7 pages instead of 1, but I just wanted a strong guideline and outline.
Appreciate it. I think we need to help, right? So I'm going to call on Dr. Yazel, who's in the south. I think you can help too in your area.
There's actually an email waiting for you in your office.
Yeah. Please engage me as well, and I can help reach out to hospitals and that I have connections with them. We can get.
I guess to help move these forward, knowing that we need to spend the dollars, I would make the motion to approve the 3 plans as presented, their year 1 budgets.
Second.
I think we hold on approving the year 2 budgets until we get further into year 1.
Agreed.
Year 1 is that, this year or
End of June 2026.
Like 11 months from
Yeah, we would expect year 2 to be updated, but I'm glad people are. Okay, so the motion on the table is to approve the strategic plans and the year 1 budgets. I approve Jonathan. Doctor there.
I support this.
Dr. Schreiber.
Approve.
Andy Van Zee,
Approved.
Dr. Weinstein,
Approve.
Dr. Jacobson,
Proof.
Fitz, Lisa Hollister,
Approve.
Dr. Landon, Dr. Welsh,
Proof.
Dr. Thomas. Okay, so the motion passes. Good job, everybody. Thank you very much. Huh? Dr. Weinstein. I did, yes. Okay, moving on to the Education Outreach Subcommittee. Dr. Lehman.
Be fast on my part and then Madeline. Well, we had one meeting since our last trauma meeting, really focused, actually, some education efforts as we always do, but also it's talking about more of the injury prevention side of our vision. So on the injury prevention side of things, we really want to figure out, and I think this is work in progress, ways in which we can establish or alongside current infrastructure to have some sort of idea of what injury prevention efforts are happening statewide. I think the track discussion is incredible, and to a certain extent, like politics, it's all local. Injury prevention is the same way. However, I think there's an opportunity to leverage our committee's work to really see where we can doing similar injury efforts and to assist in following the outcome data. So we're in some initial discussions with our IDOH counterparts on the committee to do that and see if we can't get some work statewide perspective. For some specific funding, but we are most encouraged as a committee that some of this discussion is going to go to the track level, and we will be relegated to advisory role, which we're happy to do. We did, I think, on a 30,000 foot level, we had several proposals about capital purchases, trauma sim man, other sort of mannequin type requests. We really felt that that's a track specific resource that would be best. Those discussions and funding priorities could be best left each track. So we not funded those at our plan. Questions about that?
Just real quick, I want to, I think we did a lot of work developing this infrastructure. I think we have our tracks, bless you, our bylaws, people in positions and places. I do really want to challenge and actually request that the subcommittees have clear statewide key performance indicators that we can find our ways to move forward. And I think, you know, we can't boil the ocean. So it'd really challenge everyone to not come up with any more than 3, right? Like, what is your education goal? What is our performance improvement goal, right? Do we want to do better with length of stay? Do we want to do better with, I don't know, pediatric traumas, but making sure that we have metrics that we can track as a state. And then the expectation that the tracks are helping to move those goals forward. Now they can go beyond that, but I think we do need to kind of narrow our focus so that we can show some clear improvement in direction. So just kind of before we move on to this, I wanted to, do you have any comments back to that?
Well, I mean, this is, and again, it's a little bit more difficult to speak to each track's needs, but I agree. Things of statewide importance, things like ATLS, incredibly important. We can speak to some.
I keep pediatric readiness keeps on coming up too, right? Do we have a goal that 100% of our hospitals have a pediatric readiness plan? Even though I know that's not just trauma, I think trauma is an important part of that. When that injury is a #1 cause or number 2. Thank you.
Totally agree with outcomes from all of these efforts. So everything now I'm going to talk about feeds right into everything you just heard. So these are the reports that I've been giving as I'm tracking participation. So right now, from each track, you can see the hospitals that are listed are hospitals that are engaging in grant activity right now, up to what we've been offering. Very happy to say, since our last TCC meeting, 15 more hospitals have started participating in this wonderful opportunity that we have. All trauma hospitals are participating. We have 15 critical access hospitals and 2 rehab hospitals now. And so this is just a snapshot of who is participating.
Are we getting this data back to the hospitals so that they can maybe see that they're
So we're,
missing an opportunity?
yeah, no, so we have typically quarterly meetings with leadership of CEOs of the hospitals. So we've been showing the same graphs to say, hospitals missing. That's where some of these discussions of starting to, how do we get access to some of the educational funds? So,
It's at that level. It's at our all-state webinars that we have. We have a trauma component. And every critical access hospital convening meeting, I present this information as well outside of team. So talked about a lot.
If you wouldn't mind, just if you can add to when you presented, what's the barrier? Like, why haven't you?
it's usually, there's a disconnect at, I would say, the ED operational level and leadership level. And then also the thought of like, we've already got a budget, we're already paying for these classes. Why do we need to use the grants? And it's like, no, you should use your dollars, use those dollars for activities, whether that's buying equipment or other activities, PI efforts within the department.
I think maybe so we can go from the ground up. Fitz, you want to share this with ACEP, see if they can share it out so the EDs are aware, so they can work with their leadership to potentially apply for these grants.
Absolutely.
Thank you. All right, sorry, go ahead.
Okay, these are our program activities. This is a student participation, so you can see how many students we have in all the various. These things that are on here are the ones that have been, except for the vent training, that was new. We just added, these are on the pre-approved list. And so we've had nearly 1,200 students trained, and the total funds used $326,000. So when you look at that in the grand scheme of things, we have this, our internal IDOH team meeting. It's like, got money to spend, we've got money to spend. So it's really important to see how the tracks have developed these great plans on, to not think, oh, we have all this money, we're going to spend it. It's been slow spending. And I'll show you, this is between 24 and 25. Now keep in mind, we just started tracking this in June of last year. So theoretically, we had half of a year in 2024 when we were really trying to get this out, the information and such. And so, we had a lower amount of usage. You can see by each track how dollars were spent. So when you add in total, we're just around, this was through the 15th of July and gotten a couple really big invoices in that I'm really excited about. We've spent about $500,000 just in this educational funding part. So good that we have these plans in place, and the RCCs and the team has been, they have this information. So that's helping them some of this. So what's on the schedule for the rest of the year? We do have several activities that are scheduled. We also have a couple of symposiums, if you haven't heard about it yet. And I started something new called Trauma Talks. And so Dr. Yazel kicked us off Wednesday with our first talk, 30-minute down and dirty, get people on the phone to hear what's going on. We're looking at EMS, we're looking at hospitals, we're looking at community participation. We have a traumatic brain injury trauma talk coming up on the 14th. We're going to have a talk for mental first aid for caregivers, which is also a big component of the symposium. We have unseen trauma, and then a couple other surprises up the pipe road here. Also, the Trauma Symposium registration is open. I think we're at about 100 registrations right now. 400 is our seat size. Really excited. I'd like to thank Dr. Landman for being my emotional support doctor, helping through the planning of this with the CME activity. That's the most challenging piece of planning a large symposium is the CME part. But we have some really great things lined up, and our agenda is really focused on the trauma system plan and a lot of the things that we're talking about in this room. The MCIs, recently up in Northern Indiana, so got to have a long conversation with Dr. Koenig. He's going to talk about that. We flipped his script on his presentation, talk about that. We have the RMOC conversation. It's a great time. Our track breakout sessions that we're going to have as we are really getting these tracks established. Thank you for that great idea, Dr. Weaver, and some really good training to exercises as well. So there's a stack of flyers out here. Please grab one if you don't have one, and look forward to seeing everybody.
I would love for everybody in this room to take a flyer, screenshot it, send it to your associations, American College of Physicians, the EM nurses, which I can't remember the acronym for, of course, the hospitals. You guys have lots of connections, so please share it. There's a QR code on there.
There's a QR code on there.
Quick question. So what we were talking about is I'm happy to distribute this to the emergency physicians organization. If I distribute this saying, hey, we want more of these hospitals participating in these courses, do I tell them to contact you? Or
Well,
what would
actually,
I say?
we're gonna have a shifting of the guard here soon, but it's the regional coordinators. If you want to start with me, I can get it to them, and then they will drive the bus from there.
If I send it out, they'll just want to know who
Yeah.
to contact. So
Yeah. One person right now, then once we get, they'll be connected with the right person according to their track. Great.
Moving on to Lisa and registry goals. Lisa, if you wouldn't mind trying to move relatively quickly so we can get through the rest of our agenda.
Perfect. I'm a fast talker. So, okay. Wait, you're not on the first slide?
2025 registry goals.
Okay, you want to start there? Okay. So the completeness of the registry, you can go to the next slide. So there is a surveillance program out there, and each of the commissioners have the error report. So this is just an example of showing, any possible error that existed. So there's about anywhere from 10 to 60, 80% error rate across the state. Next slide. And this is any data point. This is just AIS showing one data point. It's actually pretty good. The highest is in the 8th district that shows almost a 6% error rate. So this is just showing you, we're looking at the data. And I have to say, I totally appreciate the trauma data team at IDOH because they're amazing. This is the best I've ever seen. Next slide. This just shows you all the data points and what it looks like on the error rates on the right side. And again, you have this all in your packets. Next slide. And this is getting down to the more granular level. This is the reports that the hospitals receive. So they know on every single patient, each data point that had an error. So they have the ability to go back in and look at this and correct it. Next slide. Then the rehab data. Next slide. A rehab rep is now in the registry subcommittee. And then also I've been invited to the rehab meetings because we would like their data in the registry as well. Next slide. The registry education, and we've said this before, next slide, we've provided some education, and actually it was the ITN that did that with some state funding on AIS courses and ICD-10, and I'm still developing this online course for everybody to be able to take as a state if you're collecting data, and that is well underway. We just taped another video last week. Next slide. And then understanding the day in the life of a trauma data point and an EMS run sheet, we're still trying to figure that out. We don't understand the day in the life of these data points. Next slide. Next slide again. So I've just picked out a couple slides in that whole packet that you've got on the registry data. So we have 43,000 patients for 2024. This report is all of 2024. So an annual report. It still is a little bit preliminary. Next slide. So wanted to show you this, that statewide, our major patients with an ISS greater than 15 is in the age 15 to 24 category. Just for your awareness, that's a little alarming. Next slide. And then this is what Dr. Strebe had mentioned a little bit earlier. So the patients in the highest risk category, that red category in the triage scheme that's out there, this is showing that about 18% are not going to trauma centers. What is the goal? That's something, you know, to ask the PI committee. What is our goal? What should it be? I mean, I think it should be 100%, but what is the goal? Next slide. And this is just showing some EMS data. Roughly 16 minutes is spent on the scene. In that orange category, you know, what is the goal there? I thought it was 10 minutes. So which one is it? Next slide. Then this is just showing ED length of stay on critical patients. So this isn't transferred patients. This is just critical patients in the ER. And that trend is going up. So the length of stay in the ER for critical trauma patients is not trending in a good way. Next slide. And this is showing on the transfer patients, you know, we always wanted those patients to be transferred out in less than 2 hours, specifically the critical patients, and that's going the wrong way. So what do we want this goal to be and what are we going to do about it? Next slide. And this is overall, I love this because I mentioned this before, we've never seen complication data. So our top 2 complications are delirium and unplanned ICU. Now, sometimes the definitions change and that creates some blips like this. But here's where, you know, with some PI going on, we can create some goals and money surrounding quality. And this is the kind of data that we need to be able to do that. Next slide. This one is hospital events overall, and you might have expected that older adult events are going up. Next slide. Peds are going down. And then hospital length of stay overall, this is another trend line that's not very good. Overall hospital length of stay for all trauma patients is going up. I don't think that's the direction that we want to go. It should be going down. We should be getting better. Next slide. And then this is showing mortality, specifically deaths. And so our young are dying, so that 15 to 24 category again, and why? Firearms, gunshot wounds. So our young are dying of gunshot wounds. So something to look at. What are we doing about this? Next slide. Any questions? So you have all of that data packet, and I appreciate those that looked at it ahead of time and are questioning things. Anything that you want to see, throw it at me, send me an email. But those are some questions to prompt PI as well. And I'm also on that committee.
That one's remarkable. Excellent job. But I do want to go, I mean, shoot, let's see. I think you're right. I mean, thank you for calling out these points. I do challenge all the members of PCC and the others in the room to look through this report and identify these opportunities. And this is exactly what we should be doing. We should be saying, you know, what is the goal for people being transferred to critical patients being transferred to a trauma center? What are other states doing? What should we be striving for? What is the expectation for scene time on a trauma patient, guys?
I'd see under 10.
Under 10? Okay, there we go. So that's our goal, right? We need to put those out there. We need to develop plans to specifically address those. Those are our statewide goals, and then the tracks can figure out where their gaps are to address each of those. I will tell you your ED length of stay trending up correlates with why your hospital length of stay is trending up too. That's
Exactly. That is correlated and well published.
Yep.
And
Yep.
overcrowding.
And overcrowding, which clearly diversion isn't solving the solution there because it's getting worse. Sorry.
Right.
All right. What other questions you guys have for Lisa? That was really great. And kudos to
Thank
the
you.
data.
Yes, the data team is amazing. And they're quick and nimble with my last minute questions.
Oh, Dr. Strebe, you have your hand raised.
Yeah, I'd like to say thanks for including the mortality data. I don't think we had that before, but I think that's great to make those connections between mechanisms and frequencies and the actual mortality rates. I did also notice that when we looked at the payer source, it was one of the tables. We compared a table 43, 44 as disposition, which, you know, a third to a half of the patients are discharged with some kind of services, whether it's rehab or skilled nursing or home health care. Obviously, there's a connection between payer source and disposition and length of stay. I think those are important relationships, and maybe a conversation with our FSSA people about what's the forecast for Medicare, Medicaid going forwards.
Yeah, good points, Dr. Stride.
Great question, and we can ask our team to cross-reference that, right? So we want to look by payer type. What is their ED length of, or their hospital length of stay? Where is their discharge diagnosis? Because, I mean, I think that plays a question. It's part, it should be part of the Medicaid conversation. So again, as you guys review this, and this is still preliminary, I also, besides thinking, what should our goals be? What things should we pull out of here? Where are our biggest opportunities? Or to also ask, what other questions should we be asking of this data? Because it is really pretty much basic data, but I think it's when you combine the different metrics is where you really start to tell it. Well, that was awesome. Thank you.
Thank you.
Moving on to performance improvement. Rachel.
Be quick too. This should be pretty quick too. We kind of have two main things that were the bulk of our meeting. Number one, we did a potential performance improvement plan. And this is a mile high view of, okay, how do we take what we just talked about, right? This is what it's all about. These are potential issues we've identified. How we're going to take them to the PI committee and work its way through. Also, you know, ourselves as a committee can identify issues, and how are issues brought up from the local level for us to review. Then once that is in place, what is the actual review process? How are those performance indicators set and things like that? So this is just kind of an overview of how we do business in general. And thanks to our regional clinical coordinators, because I think they did a bulk of the work, and I think sometimes I put it out to review before they're even ready for me to do that. So thanks for putting up with me on that as well. So we did review that as a committee and put it to a vote, and we did give a final approval to that. I believe that was in your packets. So certainly if there are any concerns, feel free to bring those up now, or any revisions or anything you'd like to see out of all of us.
So the plan is not in their packets today.
Not in their packets. Okay.
We'll share it after this.
Okay, sounds good. The next one is the performance indicators. And this is where I think there needs to be some real discussion amongst the commission, our committee, things like that. This is where we actually set those parameters. Like we said, is it 10 minutes, our goal time for scene times and things like that. So, you know, that's the thing that's to be determined. Lauren's come up with a kind of a framework to go for, but I think we all need to look through it step by step, make sure it's in line with our goals and ideas, and any other things you see come up that, you know, that we've noticed from our trauma registry data or anything else. So we really would like to encourage, you know, our commission and anybody to get involved with that process, because we want to make sure we have those parameters that make sense, that are clinically impactful, and measuring what we're truly trying to put out there. So that day, that one is, and we'll get a sample out to you guys very soon to review. Reach out to me if you haven't seen it, have input, things like that. So really, those are the main two action points that we had, was the performance improvement plan and then those performance indicator reviews. So, so actually, I guess nothing to vote on yet since you haven't seen it. And our next meeting is 9/11 at 1 p.m. So any questions for me on all
Just want to make sure that whatever indicators we pick, there is evidence that it improves that. Whether that, I mean, you know, decreased length of stay is still, we know that's a good outcome, right? That's decreased cost to our entire health system, or does it affect mortality? Like, does it less than 10-minute, is that just like, that sounds good? Or does it, we know that actually improves morbidity and mortality? That'd be my only additional response. Okay.
looking at numbers, saying this is what we're going to do with that number, and this is how it's impactful instead.
Thank you. Thanks everybody on the committee and Bill's presentation. Moving on to disaster preparedness and military integration.
First, I want to compliment the members of this subcommittee. These are fantastic folks, especially those involved in the military. Dr. Major Lau, actually, we've had 2 meetings since the last Trauma Care Commission. He was actually on site overseas, and he had a very shaky Wi-Fi setup, but he still participated. It's very it's a great group to be working with. So one of the things we would ask for, I know a lot of folks are working on simulations and practice sessions, and subcommittee would like to hear about those so that members of the subcommittee can observe and learn from I know, Scott, your group in Indiana has done some fabulous work. We'd love to be copied in on that, just so we can learn from other folks. And we had a lot of discussion in the 2 meetings about plans for 2026. One of the things that we're looking to do is to see if we can get some of the folks from the subcommittee to participate in some of the other military activities in Dayton and Chicago, where they have more robust integration with military. Those are major military sites when it comes to dealing with some of these things. One of the other things we're be working on is a burn training exercise. We've already got some folks on the subcommittee volunteering to work with their hospitals. The idea is what if we had a new PAL incident like they had in Ohio, and it was people were burned, whether it was especially in a small town. How would we get those folks triaged into burn centers? And if it was a major burn disaster, we'd be quickly overwhelmed. One of the other things that we talked about, of course, like the other groups, was the RMOC. And we had a discussion about thinking outside the box of how we could respond to RMOCs that border other states, as well as one of the discussions at the COT level is what if there's a major international war? And there'd be a lot of armed forces being brought back to the states and quickly overwhelming the military system, as well as the current trauma system. We even talked about temporary hospitals in rural settings where you would have space and you would be able to bring in and egress military transports. Similar to what they did with COVID, where they had the temporary hospitals. But there's some of the things that we were talking about. We also had, I've got for your, you can go into some information on disaster preparedness. You can look at it at your own time. Like I said, we had 2 meetings. We're having some subcommittee meetings, people working on on the burn situation. We're also working on a statewide SIM involving the military. What's been done before in Indiana is National Guard, local hospital and whatnot. And one of the things we found out is there's not been a major event utilizing the military for a state. So that's one of the things we were thinking outside of the box. Again, how could we have Indiana stand out if we were integrating with military personnel, could do a SIM, and this could write some new guidelines. So if folks have ideas on that, welcome. If there is one of the plans in the subcommittee moving forward, if there is, if heaven forbid, mass casualty, be able to come in and with a debrief and a deep dive, what went well, what did not, future. One of the things that we talked about is there's one of the major sites for handling disasters here in Indianapolis. And the subcommittee on one of our meetings went to, I believe it's in the government center down the street here, is have one of our meetings there and have a SIM done as part of our meeting. So we can have a better understanding about, okay, disaster happens, what's the process, so that we can better make recommendations. It is a fantastic group. I do want to tell you about one thing listed on the Urban Search and Rescue. So Lieutenant Colonel, I can never pronounce her name correctly. It's with an S. See, yeah, there you go. I stumble on that all the time. She invited me to join National Guard and Department of Defense exercise in Urban Search and Rescue at Muscatatuck. If you haven't been to Muscatatuck, you get invited, go down there. It is amazing the work our Department of Defense is doing. So I got invited down, and apparently there was some miscommunication. She thought I was going to stand off to the side and oh yeah, okay. They have demolished buildings, and so I came ready for there. And foods, you're gonna get dirty, crawl under. So you go in and have injured folks and you evaluate, think ATLS under a building, and then you got to get them out. And then part of the exercise is, okay, we think there was 50 people in this building. We've only got 30 out. We have to figure out where the other 20 are. And then really great education. Some of the instructors were from the Israeli Defense Force. They were fabulous. They actually have a little bit different perspective on how they deal with things differently than we do. And I won't go into that, but I'd be happy to talk offline. If anybody has questions, but meeting those folks and learning from them was a lot of fun. And you know, the Department of Defense water with the electrolyte stuff, that's not too bad, but it was a perfect day, intermittent raining, hot, humid. We had a few of the military folks down for needed to step away because of the heat. But just interacting with the military folks, it's just fabulous. I came away knowing how much safer I felt. I mean, these are the folks that are on the front lines for us. Any questions?
It just reminded me, actually, Jonathan, or anybody on your team, I think it would be nice to do a quick 10-minute presentation on if there is a disaster, what that looks like from a emergency declaration, how the state EOC runs, like the coordination, how things get elevated, at what point do we actually ask, what would it look like to bring in federal help? Was that, on top of how the EMAs and the HCCs, how all these are connected in the state. I don't think that's probably common knowledge to everybody, but in the manner of people hoping and understanding they're more safe, I think that would be.
And we actually had a presentation to that effect at the subcommittee. It was very enlightening, and I think something we put together for the group, I think it would be much appreciated.
Okay.
And I think that's going to be very important as we move towards development of our mocks and our racks. I think that's the key thing that we really want to start focusing on with you is how we integrate and work together, interoperability. Updates on our mocks continue with on the federal side of things. I just attended one session 4 days ago with the American College of Surgeons. Discussions have taken place on the Pentagon level to try to figure out how we're going to address this because we don't have a national trauma emergency system. And so this is going to have to start granular at the state level. We've talked about this a lot here and how are we going to launch this? So I think that'll be an important opportunity for us to, from the racks in Indiana, to get together with you and figure out a system.
And we talked as recently as yesterday.
Wasn't it?
Gosh, I don't know. Maybe it was, I think it was 2 days ago. But we talked about this. And so I think a presentation would be great. Talk about that process. And then let's look at the next 6-12 months of planned exercises that the state has at the state level to see how those different groups could integrate into the exercise. We have our kind of common players when we look at state level exercises, but there's been some interest from this group specifically trying to get involved with them. So.
And I'd like to put a word out for my public health colleagues, whether this is a public meeting, folks on the commission, those listening, as you're working on disaster preparedness, and think about your EMS, think about your EMA, think about your local health departments. And one of the things that we were going to be working on in 2026 as we do these operations with the military is involve their EMS personnel, which right now isn't being done as much.
We have a breakout session with Lieutenant Colonel Stilianos at the Trauma Symposium too, to help with this.
Which day is that on?
Day one.
Okay. Good to know.
Guys, appreciate it. And the EMS update.
Ending week board games here today. So. Okay, first of all, I just want to put this up briefly. We have an EMS newsletter, so I know sometimes we get questions and people like to know what is going on. If you get a capture of that, or you can always email me later, but you can register or go to our website and you can register if you'd like to get those. We do that monthly. Has a lot of highlights. Certainly can hear things, the Trauma Care Commission as well. So we did meet on Friday, July 18th with the EMS Commission. And we did, as you heard, we looked at the diversion, and then we did make a couple of scope of practice changes. And one of them was adding to the EMR level administration of aspirin with medical director approval. And so that's a course that we're training, and that changes the scope slightly. Probably more important for this group, we did approve at the advanced EMT that they can give IV acetaminophen. And so that right now our advanced EMTs cannot do any kind of pain management because controlled substances are restricted to paramedic providers. And so that's a little bit of an improvement that might be able to improve some of those transfers. We currently have EMS reporting at 94,000, and we are at 25,524 clinicians. We hit 25,000 at the beginning of the year. We had spent about 3 or 4 years at 24. So that's been an improvement. So we are bringing in more people, hopefully retain them. The big thing I'm talking about this morning for a few minutes is EMS and Hospital Summit. We did hold that, and that was a collaboration that we approached. It came out of Indiana EMS 2025, and IDHS partnered with Department of Health, Hospital Association, and Rural Health Association. And we brought together representatives from the hospital side and the EMS side for a discussion of common issues that are out there. So we ended up with 25 EMS attendees and 21 hospital attendees. And frankly, everyone was engaged. Several people said it was one of the best kind of meetings or conferences that they had had. I'm going to have a summary at the end, but these are all the breakouts, so I'll go through a little bit quickly. EMS data sharing and documentation. There's inconsistent receipt, as we hear from here, but we need to make sure that the end providers have access to that. But on the other hand, EMS providers often don't get outcomes. And so they're vested in the trauma patient, but they never know what happens downstream. So a standardized interoperable data sharing infrastructure would be appreciated. Diversion practices, I think that's something that, and it was a heavy topic from the EMS side, but a statewide diversion standard with enforceable protocols is essential, was their recommendation. It sounds like the guidance that we're working on addresses a lot of that. We did discuss interfacility transfers and that they create cost, time, and then of course, kind of staff challenges in dealing with those. And behavioral is one of the big ones that are there. And I think part of this came out of a little bit of, we heard a discussion of RMAC from Texas, where they were talking about they had behavioral as well. And so in the breakout session, that was a follow-up that people identified with and said, they seem to be handling it well. Can we look at doing that? Because their system looks at taking the patient, figuring out where the resources are, and get the patient to the right resource rather than funneling through an emergency department. And then staffing certification concerns, talked about underutilization of the advanced EMT, burnout, and then we also could look at reform of the education pathways. And the regional coordination and technology was one of the takeaways as well. And so I think you would hear consensus for your concept that we hear here with the RMOC. I think EMS and the hospitals seemed very interested in exploring that. So this is just kind of the high level takeaway from there that you look at diversion, data sharing, interfacility transfers, staffing, scope of practice, take a look. One of the things I know the Hospital Association Andy is interested in, can we look at our staffing on ambulances for transfers, even maybe non-EMS providers, things of that nature that might open up flexibility. And then, of course, looking at other state models, see where we can make improvements. The last thing I have is a follow-up on the data. Last time we had some great questions, and we did schedule ImageTrend as the state repository for EMS data. We have access, IDHS and IDOH uses ImageTrend as well. They do have something called Hospital Hub, which is a shared communication. And what is interesting is it is bi-directional, so that way you can give feedback and providers can even request feedback on their runs. And then the receiving hospitals can transmit back, but the receiving hospitals have better access to logging in and seeing if it's in the state system. Obviously, if it's never submitted for some reason, the state system, they still wouldn't see it. But where we try to keep our submission rates closer to 100%, most of the runs should be in there. We did, in this meeting, we had Department of Health, had representatives. Madeline was on there. I think we're going to need to explore it a little bit more. We just wanted to let people know that we're looking at it. It actually is very cost effective. It may be something that we might want to look at, either shared or look at trauma system funding. And then we can look at our end when we bid for Image Trend next, because it was not as expensive as we thought. But we do feel there are a lot of benefits that could come out of that. So we're going to continue exploring. With that, I'm open to any question. Our next EMS Commission meeting will be in connection with the Indiana Merger Fund.
Any final comments? Open it up to public days. Would you like to move to adjourn the meeting?
So moved.
Second.
All in favor?
Hi.
Break the rules there. All right. Thank you guys, everybody. Great meeting.
Good drill. Down there for a second.
Oh, yeah. The shows up. I got there early.
We're gonna put him right in.